So today we have with us Dr. Holmgresner. Most of you know him. He's the R&D and ERN coordinator. He will be giving us an overview of rare disease care pathways in the EU. We will then have Sara Talarico, Dr. Sara Talarico, who's a rheumatologist, and she is also part of Reconnect coordination team. And she will be presenting the rare ERN path methodology, something that the Reconnect people have been working on for quite a bit this year and last year, I think. And we have also with us this afternoon Professor Eileen Tracy, who is a clinical lead at the National Rare Diseases Office in Ireland, and she's also the ERN Board of Member State representative. And with her is Dr. Alana Ward, PhD in National Rare Disease, also working at the National Rare Diseases Office in Ireland, and they will be representing a very interesting experience that they've been having and developing, and work they've been doing around care pathways in Ireland. After them, then Dr. Holmgresner will present the experience with the German National Care Pathway for the Undiagnosed. And we will have a little bit of time for questions and answers. We will be managed by my colleague Matt Johnson. Sorry for that. There's a typo in your surname, Matt. Sorry for that. And then we will do just a wrap up. So I want to also let you know that Alana and Eileen, their Wi-Fi was not so good, so they have pre-recorded their presentations. So we will be playing a video, and they will be in the session to answer any questions that you might have. So they've been kind enough to pre-record their presentation. So without any further ado, I'm now stopping my screen sharing, and I'm giving the floor to Holm. Please go ahead.
Yes, thank you very much, Ines. Just sharing my presentation. Put it into the presentation mode, and here we go. So thanks a lot for the invitation. As said, my name is Holmgresner. I'm the ERN coordinator, but also I'm the managing director of the Rare Disease Center at the University Hospital in Tübingen, Germany, which will play a role in my second part today. But with that presentation now, I would like to give you a bit of an introduction into care pathways, to be more precise into rare disease care pathways. And with that, I would like to set the scene. So we'll be touching on 6 points. So I will be giving you a definition what care pathways are. I will be showing you an example. And then I will be having a few slides on challenges. So first on rare diseases in general, then challenges for rare disease care pathways. After that, I will present at least a selection of components and characteristics of rare disease care pathways. And in the end, I will be wrapping up with the role and also the opportunities and challenges European reference networks can play in rare disease care pathways. So let's start with the definition. So care pathways, and that's really the definition, care pathways structure care processes and improve them within the patient-centered care concept. And care pathways, and I think this is one important thing to understand, care pathways really change the care as being provided. So there are interventions. And I would like to mention 4 features of care pathways. So first, they are a structured multidisciplinary plan of care. So multidisciplinary is there the keyword. Then they translate guidelines or evidence into local structures, so local or regional structures. The third feature is that the intervention details steps in a course of care. So it's really step-by-step approach, which what makes a care pathway. And the fourth feature I would like to mention that that care pathways aim to standardize care for a specific population. So it's not an approach for the entire population of patients, but very specific for a certain disease. To put it a bit to the point, one can say that care pathways aim to have the right person and the right place, doing the right thing at the right time with the right outcome, and all with the attention to the patient experience. And all what I say today, at least in this introductory part, can also be found in a publication I've published together with the Bureau de Tomiene this year in the Journal of Community Genetics, and you see the reference there. The picture I'm showing you is a diagnostic flowchart we have developed in our Youth Reference Network, and this is actually a type of evidence which can be used to translate into a local or regional care path. We are not detailed that much further. That's really, as you see, a stepwise approach, because well, we call it actually a diagnostic flowchart. So that's another example I wanted to show you. That's the example for cervical dystonia, and it's not yet a care pathway actually. So it's a patient journey, and we developed this patient journey in our network with the aim to have an input for the development of a care pathway. And I think the typical features you see already. It's stepwise, it's a clear order of steps, it's multidisciplinary, and at least in this case, it really leads from diagnosis to treatment and continued treatment. So what challenges are attached with establishing rare disease care pathways? So first, of course, there are challenges which are related to rare diseases in general. And I'm not going to dive into the characteristics of rare diseases listed here. So I think it's clear that rare diseases in general make it quite complex to develop care pathways. But also there's the challenge in terms of resources. I think it's also a no-brainer that no European country alone will be able to solve all the rare disease-related issues, meaning that also for care pathway, it makes a whole lot of sense to collaborate on European level. So what are the challenges for rare disease care pathways and to set up a rare disease care pathway? Of course, although we will be hearing today about a few care pathways, there's still a huge lack of care pathways for rare diseases. And that's at least partially due to the fact there's a lack of evidence-based resources, which can be translated into care pathways. Of course, and that's, I think, already covered by the rare disease characteristics I mentioned. There's a large scope and complexity of rare disease care pathways. And in terms of diagnosis, and I think that's another complexity, another difficulty rare disease care pathways have to deal with. There's, of course, the difficulty to define the entry point for rare disease care pathway, because that's linked to diagnosis, and to have a clear diagnosis for a rare disease is still an issue. And then there are, of course, two kind of organizational challenges. One is support and financial incentives, and the second one is the need to benchmark and to monitor existing care pathways. So if one looks at care pathways, at rare disease care pathways, one could identify specific components and characteristics. So firstly, there is a substantial load for a highly specialized service. And this is mainly due to the fact that we're dealing with highly complex diseases, where the respective resource and expertise is just being held as at specific, well, let's say points where these highly specialized services can be provided. And therefore, another component is, or another characteristic is that is that we're talking about centralization of services. In a few European countries, that's a difficult notion, but for a rare disease care pathway, that's certainly really important. Of course, a rare disease care pathway needs to strike a balance between highly specialized and less specialized services, because it needs to include all the care providers which are needed for the respective care pathway. Then, as mentioned, and that I alluded that already, there's really the issue of gatekeeping. So how could we actually have a functional gatekeeping to the respective care pathway, meaning in most cases at least having the right diagnosis for a rare disease patient. Then, of course, it's important to have patient empowerment and self-management, or, and I mentioned this here explicitly. I think also the role of a care coordinator could come in here. For most rare disease care pathways, IT technology will play or plays a role, and also the link between healthcare and research. And of course, as a care pathway, it's not just a horizontal integration, but also a vertical integration of the respective services. A respective care pathway need to bridge to psychosocial and community care. So, having presented you with the challenges, I should say that
1 minute to go home. You have 1 minute.
Okay. I should say that the European Reference Network can really be a game changer for a rare disease care pathway, and that's for two reasons. So one, they are part of at least the cross-border healthcare pathways. And second, they provide the knowledge, the evidence, which can be used for implementation of care pathways on local and regional level. So what role can they play, and what opportunities are there? So of course, as said, they provide the access to the knowledge and to the highly specialized services. With the European Reference Networks, we can implement an economy of scale. The scope can be enlarged, and also a respective speed of delivering the care pathways and the respective care can be introduced. And the other thing I wanted to mention, and I leave it at that, is that the European Reference Networks provide a essential part of cross-border pathways, care pathways for rare disease patients, because they provide multidisciplinary consultations for complex patients. And this is being provided in the CPMS, in the Clinical Patient Management System. And I believe that the Clinical Patient Management System should be part of any cross-border healthcare pathway for rare diseases. So there are, of course, a few issues which we need to address, and I just mentioned two. And the issues are that there's a bit of a lack of a power to really address the rare disease care pathway issues on European-wide level, because the responsibility for healthcare is with the member states, and that's a issue we face at the moment and try to address properly. There's still a missing, or let's say only a partially established integration of the ERNs in the national health system. And that's one of the conditions really to have functional cross-border healthcare pathways for rare diseases. And with that, I do thank you and hand over again to Ines.
Thanks, Holm. That was very good. And now I'm going to give the floor to Sara Talarico, who's going to explain a little bit what RECONNECT has been developing in this area and how the ERNs could develop themselves care pathways and how these are different to the care pathways that can be developed at member state level. So please, Sara, go ahead.
Thank you. Can you hear me? Okay, first of all, thank you to Ines and thank you to all the organization team for giving us the opportunity to bring to you and present to you our results and our approach. I'm Rosario Talarico, even if everyone calls me Sara. I'm a rheumatologist and I work in the coordination team of the ERN Reconnect. What I'm wanna do in the next 20 minutes is to present our approach, our experience. Obviously, I'm representing now not only ERN Reconnect, but also the Institute of Management of Scuola Superiore Sant'Anna, in which Professor Turchetti and other experts in the health economists worked in this huge work in creating this approach. What we are talking about? We are talking about organization, since we know, and as clinicians, I know very well that we have patients' care pathways, even if we have other types of patients' pathways, social care, or other level of patient pathways. But what we learned working in the coordination team of the ERN Reconnect together with this expert in the economics, health economics, is that organization matters a lot, especially for rare disease. And this is why this kind of approach called Reverend Path, probably many of you observed this name in some presentation, is aimed at talking about organization point of view of patient's pathway. And it is a method and a methodological approach aimed at design a common organization reference model for patient's pathways. We work on rheumatic disease, but the method is applicable in other fields for rare disease and probably also in other non-rare disease, also complex. One important thing, and what I would like to highlight, is we are not talking about a standard model, but about a reference model, since we are talking about European countries and we are talking about rare disease. So no one approach, nobody is standard in the field of rare disease as clinicians, as patients and stakeholders. We may work on reference, something that is referent and applicable in order to improve all the activity, also the patient's care pathways that we already have, or for the new one regarding rare disease. This approach was developed in the framework of European Reference Network, and for this reason, the milestone, the very big principle of the European Reference Network is the core of this approach, the patient-centered approach. So we look at this kind of patient's pathway and the approach taking care of the patient-centered care. In other words, patients worked with us in creating, in analyzing and defining, finalizing also the approach. And obviously it's foresee integration with different stakeholders and especially a monitoring process. Since if we are looking at something regarding rare disease or other approach in health system, we have to monitor these aspects. Otherwise, we are only observing. I'm showing this slide since we as clinicians, but as patients, as a rare disease community, we can say that pandemic lead to our mind and our thoughts many lessons learned. And one of the main lessons learned is that organization matters a lot, since we have to consider that organization is important in order to go ahead on the clinical care pathways that we are going to apply. And during the pandemic, we had a lot of problems regarding organization for care of patients in general, about information regarding COVID, uncertainty for the availability of many drugs, provision of telemedicine, and so on. We know this problem very well. So again, we learned that we have to work on a methodological approach that can be sustainable for the organizational point of view. In these slides, you can see the different phases of this approach, of the Redden path approach. And when summarizing the aspects, the main aspects of this phase, I would like to show, in the meantime, some practical results that we have since we applied this methodology in our disease, rare connective and complex connective tissue disease, and hopefully in other fields outside of the rheumatic disease, and probably summarizing what the phase is together with the results is more simple and more easy to catch. The phases are represented by the point of view of the European Reference Network. So we start from the experience of patients and clinicians in excellent centers and also outside, and try to have something to apply, to integrate at local, national level. So we started with mapping all the experience from patients and from clinicians at patients' care pathways, since we are focusing in this case in patients' care pathways, even if we are working also together with Olm on the other aspects of the patient's pathway, patients' pathway in the social care and in other field of the life of patients and patients' community. So the first phase is to map, starting with a state of the art on what we have in the different HCP. So from the clinician's point of view and also from the patient's point of view. The aim was and is in the approach to get the picture of the current practice in this case, since we are rheumatologists in rare connective tissue disease organization, since what we observed and what is aimed to search this phase is to look at the organization. We know very well that we have many clinical practice guidelines in every field. Some clinical practice guidelines are lacking probably for some rare disease, since we do not have sufficient evidence to have clinical practice guidelines. But we know as rare disease community that the application of clinical practice guidelines is not so easy in real life. And focusing on the organization is the driving force to apply clinical practice guidelines. So as European Reference Network, we started from collecting the experience of clinicians, of expert clinicians, since within the ERN we have excellent center for rare diseases and endorsed for the disease in ReConnect. Collecting their experience as organization of patients' care pathway, and at the same time, collection patients' perspective. How we did this kind of map? We structured the questionnaire based on the organizational analysis of patients' pathway. And we transferred these results for each HCP involved in a flowchart, and this flowchart was validated together with the clinicians, with the HCP representative, also with the possibility to add some material, informal material or other material at disposal of the HCP for patients in order to inform them on patients' care pathway. This is the case of systemic sclerosis, the first disease in which we applied the methodology, and we involved all the HCP involved and endorsed for the disease, but actually also other two centers not endorsed, but taking care of the disease. And we mapped their experience on a diagnosis phase, on therapeutical phase, and monitoring, and so on. What we try to collect. In the first phase, managing this approach, we observed many challenges with the clinicians. And as a clinician, I have to say that the first thoughts when we are talking about organization and receiving such a questionnaire, the clinician can think, okay, I have to summarize the clinical practice guidelines that I'm applying in routinary care. No, it was not the correct answer, since we were searching for the real organization, useful for applying clinical practice guidelines. For example, agenda dedicated for any disease, an inpatient focus for the disease or for the group the disease. And we asked for how do you are organized in your clinic for taking care of this disease. It is a little bit different of clinical practice guidelines or summarizing the clinical practice guidelines. We know them. We are talking about how do you apply this in real life? How do you organize? On the other hand, we collected the patient's perspective, and in order to do that, we used the approach of narrative medicine, a very interesting approach that we used in order to collect patient story with a very huge work from patients. We are very lucky in our coordination team. We have Diana Marinello. She is very expert in managing patient empowerment and also and mainly from the research point of view. And she managed the coordinated the volunteers. We have many volunteers that cooperate in the translation in different languages in order to catch the story. We launched the survey in the platform EU Survey that is free, anonymous, and we collected many stories, more than 200 stories that we collected in a book, and we are doing the same for the other disease. We collected this information and we put together all this information in a common patient's pathways, providing the different feedback for the different HCP. How? We try to put together.
Sara, you have 7 minutes to go. Huh?
Yes, thank you. We collected together the different experience of patient's pathway from the clinician point of view, and also all the feedback received from patient stories. We have many approach in order to elaborate patient story, in order to identify needs and priority related to care and pathway. For example, in this case, for systemic sclerosis, we analyzed all the stories, and as you can see, this is a simple word cloud, but representing many things and many huge and challenges that patients experience. We have for other disease, the biggest word are represented more frequently in the text, and we have in many cases diagnosis as a big word, the latency to diagnosis or access to care. There are several problems represented. What we did, we analyzed the common issue from patient story, we identified the challenges and point of strength, and we discussed it together during the meeting. In this meeting, this was for systemic sclerosis before the pandemic. We had a consensus with patients, with EPAG, patients from other community, rare disease community, but not EPAG. So also patients not actively involved in the ERN Reconnect, clinicians and other stakeholders. We have also the possibility to share this information with our hospital manager, since the result of Rare and Path is not a summary of all the experience of the challenges, but talking together about the organization. We know very well the content as clinicians and also as patients of the visits, laboratory tests for systemic sclerosis. But what is important is how organize the flows from emergency department to the inpatient care. And we experienced very challenges during the pandemic. How is organized the flow? You have to call your friend in emergency department. You have a dedicated agenda for the cardiologist. How is organized? And we highlight what is important to organize, that in many cases is similar to clinical practice guidelines, but from the point of view of the organization. And it was very important that many aspects included in the clinical practice guidelines are included also in this result of the flowchart, but many other aspects are new. For example, from the patient story, patients highlight the need to have, as a systemic sclerosis patients, a psychologist in the specialist visit, and the psychologist is not included in current clinical practice guidelines. In other aspects, there are many aspects, and I have not sufficient time to explain, but another aspect was the information regarding the clinical practice guide, the patient's care pathways, since as many patients highlight during in the text of the story, if a patient does not know that there is a patient's care pathway, and if doesn't know the information related to be part of a patient's pathway, they perceive the patient care pathway organization as a sort of labyrinth. And this is very important, since from the clinician's point of view, the organization is it's a very good thing, but the information related to this organization is important as well. Obviously, since we are talking about organization, we cannot not considering the monitoring of this activity. So we co-designed the phase of the methodologies to co-design key performance indicators in order to monitor the apply of the results of the patient's care pathway of the reference model. So we co-designed together with patients and the different stakeholders, different process indicators, access to care, and many other. There are a lot of KPI in this process. And also we launched the pilot phase for systemic sclerosis, and we are launching for the other disease, since what is important is the flexibility and applicability of the reference model, since again, it is a reference model, not a standard model. Countries are different, the local HCP are different, so it is important to apply in order to improve by means of the organization the real application of clinical practice guidelines, even if when a patient care pathways already exist. It is also important to consider, since we are working together with economists, evaluation of the cost. And there is a software and many other aspects related to these aspects. Also, a sort of self-management that each HCP should be considered before applying for the pilot phase. And the pilot phase, in other words, means that we observe the activity, the collection of KPI without the reference model in 6 months, and then after the application of the reference model. We are observing now, this is a process ongoing, we will expect many different aspects regarding cost, regarding benefit from the outcome of the disease, from the organization itself, and we will expect that improving organization really can improve the outcome of rare disease patients. After this phase, the last phase is to refine, according to the different countries, the result, so the reference model for the specific patient's care pathway. In conclusion, in our perspective, and from our perspective, what we learned that the results of rare and path, since rare and path is a methodology, provide the results. The results of rare and path application is a reference model for each disease, over single disease or group of disease. And it is a result of the European reference network model, different stakeholders involved, patient-centered approach, different perspectives, since it's the added value of the European reference network. Otherwise, we are talking about simple organization challenges. We collected the organization from the different point of view, and we try to find a solution of these organizational challenges. Point of strength, first, flexibility, adaptability, and monitor this process. In other words, this is our point of view to translate in integrate in the local care, and vice versa, also local care to the European level. Since from the expert of excellence, we can find and we can observe many challenges, but also many good practice, and try to apply at local level, since The results of rare path application is what we have to do routinely as clinicians, as patients, as a stakeholder, hospital manager, and it is important to apply. Otherwise, European reference network are in level, local level is another level, not up or down, but different level. In this way, we are trying to applying what is the excellence, what are the clinical practice guides in the reality. Thank you.
Brilliant. Thank you for that, Sarah. I have lots of questions, but this is a very interesting exercise that you did, and I'm sure we will be using it a lot in the future. Now I'm going to share my screen. I'm going to share the video that Eileen and Alana pre-recorded. So let me share my screen. Advanced video. Okay, there we go. Yeah, it was great, Sarah. Can you see my screen like full screen, or is that okay?
Good afternoon. We are very pleased to have the opportunity to join you today to review our experience in developing a model for the design of rare disease care pathways in cooperation with our national rare disease patient advocates. My name is Eileen Tracy. I am the clinical lead for the National Rare Disease Office in Dublin, Ireland, and I am the Irish representative on the European Commission European Reference Networks Board of Member States. Joining me today is my colleague, Dr. Alana Ward, Information Scientist at the National Rare Disease Office, who will be presenting the working model that we have developed. The National Rare Disease Office.
So stop, it's not, sorry, it's not actually moving. Okay, I'm gonna have to use this. Yeah, okay, next slide.
The National Rare Disease Office is situated here in the original old building of the Mater Hospital in Dublin. This office was opened in 2015 as a key recommendation of Ireland's first national plan for rare diseases. The office has a number of national rare disease coordination functions, including hosting Orphanet Ireland, an information line, and coordinating our national European reference network activity. Ireland is a small member state with a population of approximately 5 million. We estimate thus that there are at least 300,000 Irish residents affected with a rare disease. In a small country such as Ireland, you can understand that the well-described, delayed and fragmented diagnostic and care journey for many patients with rare diseases may actually be more problematic than in larger member states that have greater capacity. Thus, the development of robust, integrated diagnostic and care pathways and cooperation with other member states for the highly specialized resources needed for rare diseases offered by the European reference network structures is of great interest to our rare disease community. Following the ERNs-led Europlan national consultations to develop national rare disease plans in 2012, the main concerns, as noted by our rare disease community, were the prolonged and difficult diagnostic journey, the lack of information in our health systems about rare diseases, and the lack of awareness of rare diseases in the community. We also know from our ongoing research that there is a higher incidence of rare diseases for those conditions that are screened for by our newborn screening program in Ireland in comparison to neighbouring countries. We also know that rare diseases are very prominent in our paediatric practices. As emphasised once again by the COVID-19 pandemic, we have noted a major gap in knowledge about rare diseases in primary care at general practitioner level. As we've noted from an audit of GPs in Ireland that we performed, inadequate education and training in rare diseases in the community is partly responsible for many of the challenges faced by rare disease patients in Ireland. So as you probably know, Ireland published its first national plan for rare diseases in 2015. The National Clinical Programme for Rare Diseases developed a model of care for individuals affected with rare diseases in Ireland in 2019. This further elaborates how care would optimally be provided to rare disease individuals in Ireland with integration of our rare diseases centres of expertise into European reference networks. So in terms of policy, national policy, Sláinte Care is the current national Irish Department of Health initiative for healthcare reform in Ireland. Sláinte Care emphasises equal access to services for all and if possible, delivery of care as close to home if feasible. We've heard from the earlier speakers today about the goals of the European reference networks with the objectives to improve access to diagnosis and high quality, accessible and cost-effective healthcare for patients who require a particular concentration of expertise or resources. It was noted at the conception stages of the development of these networks that there would be stepwise and progressive implementation of the goals and priorities of the networks. What you will see from this slide is the recent Rare Barometer 2021 study has also highlighted the top 3 unmet needs for people with rare diseases in Europe to be addressed by 2030. These are the requirements for better care coordination between healthcare professionals, the improved access to specialists for the disease, and enhanced treatment opportunities. This schema from Dr. Terrell at the European Commission illustrates how patients ideally could access expert care and treatment through their national designated rare diseases healthcare providers in collaboration with the ERNs for the sharing of care, research, and knowledge generation. As we've heard earlier, the 2019 Board of Member States position statement encourages the integration of ERNs into the national healthcare systems by developing national rare disease plans and strategies and clinical care pathways for patients. So in the context of development of our care pathway model, which is linked to the ERNs, I would first like to illustrate our current national rare diseases infrastructure. Since Orphanet was established in Ireland in 2015, we have now validated 85 expert rare disease clinics using the Orphanet standard validation criteria. Ireland joined a small number of ERNs in 2017. However, we now have positive evaluations from mainly consortia to join the majority of the ERNs in November of this year. The leads of the applications nominated from an open national call are actually grouped from 5 major academic teaching hospitals based in Dublin. These institutions combine care with research and teaching and are affiliated with our national universities. In this model, the Rare Disease Office is central to this hub and spoke model, and whereby the majority of the leads collaborate with other regional hospitals for the delivery of the agreed care pathway. Now I will hand you over to my colleague Alana, who will describe the model that we have developed.
That's it, okay. Thank you, Ali. So we set out to pilot a methodology to develop rare disease care pathways within the Irish healthcare system. We wanted to focus on chronic, multi-systemic conditions needing multidisciplinary care. 30 rare conditions were selected based on their prevalence, the existence of Irish clinical expertise, and representation across 18 of the European reference networks. These were non-cancer, as cancer conditions come under a different governance structure within Ireland. So here you can see the 30 rare diseases that were chosen, one of which was not progressed, as the Irish prevalence is not as great as our initial estimates. We intend that these care pathways will be relevant for patients and carers, clinical experts, GPs, and health and social care professionals, physiotherapists, occupational therapists, speech and language therapists, and the more psychosocial roles, medical social workers, psychologists, and also reaching out to health service managers as effective maps to diagnosis and care and advocacy tools for business planning. So what was our plan? We set out to present the expected level of care for each of the selected rare diseases, founded on evidence-based, validated clinical practice guidelines where possible. By close engagement with our clinical Irish experts and patient representatives, we aimed to map these CPGs onto the Irish healthcare system. The goal is improved diagnosis and care, leading to positive patient outcomes. So here is the process that we used. Our starting point was an audit of clinical practice guidelines from relevant ERN websites, Orphanet, and PubMed. These formed the basis of a first draft care pathway for each of the 30 conditions. These were revised by Irish clinical expert leads. Patient representatives were identified through Orphanet validated national patient organisations, with the huge support of the umbrella group Rare Diseases Ireland. Patient rep consultation feedback was then reviewed again by clinical leads for incorporation into each pathway, as the clinical governance for each pathway is under the responsibility of the clinical leads. We are now reaching out to other key stakeholders to ensure a national primary care, disability service, digital e-health and integrated care programme perspective. The goal is for live and updatable care pathways with regular review to ensure evolving care guidelines and treatment opportunities are captured. A major challenge will be dissemination and effective integration. So just to talk a little bit about our experience with patient representatives. Rare Diseases Ireland is a patient advocacy national alliance for voluntary groups representing people affected by or at risk of developing a rare disease. They have been, and we hope will continue to play, a central role in ensuring positive and constructive engagement with national patient representatives by helping us to map the patient representatives, co-creating support material, co-hosting video workshops to introduce and support the project, and providing email and phone support. We believe this will furthermore lead to co-promotion and effective dissemination. So here is the basic template for our care pathway model. You can see it's divided into individual sections. The diagnosis section will lay out common signs and symptoms, diagnostic criteria where they exist, and which disciplines are involved in diagnosis. Each of the care sections has the details for the specialists involved, listed under hospital-based, community and primary-driven care, or shared care, based on where the care is delivered. So here's an example of the NF1 care pathway. Patients, GPs, and healthcare professionals can use the pathways as overall guides to diagnosis and care, or more specifically, click on each section. For example, I may be concerned because my child has NF1 and I wonder about their eyes. My GP can simply click on the ophthalmology section to see what screening is advised. Okay, so I'm hoping to show you a little video here of the interactive features of the care pathway model. As you can see, if you click on each section, the details are displayed for each aspect of diagnosis and care. We also have sections along the side for Orphanet information, relevant references, and clinical lead information. We asked clinical leads to detail the resources and link services necessary to deliver the care outlined in their pathway for a cohort of patients. In this way, we hope the care pathways can be used as advocacy tools in business planning for service commissioning. Our patient representative feedback identified common priorities across all conditions: an appointed healthcare professional with a coordination role, care in the community, close to home where possible, psychological support at key milestones, diagnosis and transition in the patient journey, improved healthcare professional and patient awareness of community supports and access to these supports. Each clinical lead and patient rep was asked to detail the health and social care professionals necessary for each condition: nurse specialist, physiotherapy, occupational therapy, speech and language, psychology, genetic counselling and database managers for registry development were considered. Clinical leads and patient representatives considered nurse specialists, psychology, medical social work and database managers as core roles in 100% of pathways. Health and social care professionals, physio, OT and speech and language were key in over 75%, genetic counselling in over 90%. Patient representatives in particular attributed high value to health and social care professional roles and psychosocial roles. Patient partnership is central to our methodology. The European Joint Programme have compiled a great short guide which is very useful for anyone embarking on research with a desire to embrace the patient voice. In the EJP guide, they highlight the many benefits of placing rare disease patients at the heart of research methodology. Our own experience has certainly confirmed this. Personally speaking, engaging with patient organisations has been hugely motivating and inspiring. Our patient feedback has enhanced the relevance and practical aspects. For example, my child may have PKU and been prescribed a strict diet, but it was our time with the play therapist which was so valuable in helping us with compliance. Our project also highlighted some particular gaps for rare disease patients: access to psychology at key points, transition to adult services, a lack of adult services, particularly for neurodevelopmental conditions, for example, NF1, Angelman syndrome, and 22q deletion syndrome, and concerns around lack of care coordination. There are considerable challenges in rare disease care pathway development. There are limited ERN endorsed clinical practice guidelines. CPGs for rare diseases are often based on lower levels of evidence, out of date, or focused on a single body system. Clinical leads engaged well, but it was so evident that time pressure was a significant factor. We struggled to engage primary care stakeholders. However, we are making progress on this essential element. For most care pathways, many different healthcare professionals and specialists were involved. We took a more pragmatic approach and asked clinical leads from the most relevant ERN to outline all disciplines. Patient rep identification was through Orphanet with huge support from Rare Diseases Ireland. For several conditions, no national patient organisation exists. Clinical leads and Rare Diseases Ireland identified 2 or 3 individuals who could feed back. We were aware of the vulnerability and pressure of taking on this responsibility whilst managing their own or relatives' rare condition. RDI provided significant support. EPIG identification for each ERN is ongoing and will provide great opportunity for patient engagement as pathways evolve. Patient reps and clinical leads asked us how aspirational or how realistic should these pathways be. This was challenging. We asked them to outline the expected level of care for each condition. The final implementation will be a significant challenge and will require service commissioning. By further engagement with primary care, we hope to explore how care pathways can better support and inform GPs, developing red flags to aid diagnosis, map appropriate referral pathways for diagnosis and care, and define the role of the GP in care and care coordination. Liaison with National Disability Services ensure our model accurately reflects how services are delivered on the ground and can adapt to evolving service configuration. With our national digital e-health connection, we hope to move towards developing a website to host the care pathways and make them live documents that can be updated as new treatment and care guidelines emerge. Patient representative feedback strongly favoured psychosocial links to improve awareness of and access to community, well-being, carer, education, employment, welfare and counselling supports. So as you can see, this is very much a work in progress and there is a long road ahead. Despite the many challenges we face, we consider national rare disease care pathway development an achievable and valuable goal. Foundation stones are ERN endorsed clinical practice guidelines, positive engagement with national clinical specialists within our centres of expertise, ERNs and access to expert network care, alignment with national healthcare initiatives such as sponsor care. The patient's expert lived experience is central. It is our hope this will lead rare disease patients towards more timely diagnosis, coordinated integrated care and positive patient outcomes. And finally, sincere thanks to all our partners and collaborators as outlined on this final slide. Many thanks.
Okay, so that was the presentation from Eileen and Alana. Again, lots of questions. There are lots of questions already on the chat. I see people are switched on. That's good. Holm, now on you. I'm going to resume recording so that you can present your slides, and I'll pause it now. Hold on a minute. Yes, thank you for that, Holm. So we open now the floor for questions and answers. I see lots of questions in the chat. So we'll try to answer all your questions now. Matt, do you want to bring them forward to the panelists, please?
Yes, just typing. So we've had lots of questions. Thanks a lot to everyone who's presented, because I think they've been really great thanks a lot to everyone who's been presented. They've been really great presentations. So I'm just going to field these if that's okay. First of all, we had a couple of questions, and I know, Holmes, you were putting in the chat some definitions, but there was some people wanted clarification on the difference between a care or patient pathway. Are they the same thing? And how are they related to the patient journey? So I think they wanted to understand sort of the difference in this language. I don't know whether you wanted to add anything from what you put in the chat.
Yeah, so I can add a few things. So first thing, care pathways are patient-centered. So at least in my terminology, I don't use patient pathway, but I use care pathway, because it's about organization of care. And one of the features of the care pathway is that they are patient-centered. And when one starts to develop a care pathway, and perhaps Sarah is and Elena and Eileen are better suited to answer that question and comment on that. If one starts to develop a care pathway, one of the means which one can use is a patient journey, because it actually defines the needs of the patients in terms of organization of care, and that can nicely input in the development and also then in the implementation of the care pathway.
Holm, can you briefly also comment on the difference between a clinical practice guideline and a care pathway, because it was also in the chat, and I want once and for all that this is clear for everyone. So please go ahead.
So clinical practice guidelines are evidence-based best practice, clinical best practice, and they are kind of translated into regional care organization, local care organization, and cross-border care organization through the care pathways. That's my, in one sentence, relation definition.
So just to add to that, because I think both Alana and Eileen and Sarah both were quite clear about one, using patient journeys in how they redesign their pathways. But I really liked Sarah's definition of how a pathway gives more tolerance, more room to be more patient-centered. So the needs which was raised about more psychological support, you could build your pathways based on the evidence-based, but based on that local needs, on the needs of patients which you engage with, you can expand on that. And I don't know, Sarah, whether you wanted to add a bit more to that.
Yes, thanks. Yes, I totally agree with what already said by Holm. We know that the main definition of clinical practice guidelines, we know that is the definition of the Institute of Medicine, and they say that clinical practice guidelines are statements or recommendations, but always evidence-based. So we know that we have clinical practice guidelines when we have evidence for producing clinical practice guidelines. In some cases, and this is particularly true for rare disease, we have some cases in which we have to use not evidence-based, in some case eminence-based, in some case experience-based. It is different regarding the different field of rare disease, as well as for other not rare complex disease. The pathway, when we discussed a lot together with Professor Turchetti, designing this kind of approach, since he's the expert of the organization in health, and we discussed a lot in producing this approach. And we said, okay, we know that there are a lot of methodology in order to produce pathway. This is the old way to look at the pathways, but since we are working in a European reference network, in a network of rare disease, also before the ERN, we have to upgrade this methodology, this kind of view of the pathway. And this is the time in which the patient-centered care pathways come up, since the old definition of care pathways of patients' pathways, since we have patients' pathway means many things, means organization, means application of clinical practice guidelines, and we choose the definition of patients' care pathways when talking about RN path, since there are a lot of other dimensions, the patient social pathway, the patient workability, and many other dimensions. So when we approaching to RN path, we define the patient care pathway, we define all the organization, all the tool, all the support for the application of clinical practice guidelines or other recommendation, even if not evidence-based. But the patient care pathway is the organization in the last decades with the patient-centered, since patients participate in the designing of the patient care pathway. This is the new way to approach to the pathway. And what we learned in the European Reference Network, that patient is the center not only of the designing process, but also on the actor that says, okay, I have this challenge, I have this best practice in my center, what we can do in order to improve the reference model. Patient care pathway means for rheumatic disease, we have many diseases, but each disease is different to the other. This is a very difficult and challenging work. So this is the way talking about patient care pathway means organization, application of the clinical practice guidelines, what do you have to do in your hospital, all the main aspects that we have in the hospital, but also outside the hospital, since patient care pathways for many diseases means also outside the HCP, for physiotherapy or other aspects. What we learn is not only the psychological impact of the patient's pathway, but the needs from the point of view of the patient. I'm a clinician, and as clinician, before working on patient care pathways together in the framework of the ERN, I saw the patient care pathways as the best way to apply the clinical practice guidelines. From my point of view, and I'm a doctor, but from the point of view of patients, it is a different way. This is the same form, look at from different perspective. And work in ERN and work together in a community of rare disease means work together in order to design and look at the form from the top all together as a group, not from different perspectives. I don't know if I was quite clear, but.
Thanks, Sarah. Eileen, do you want to add something? I saw you raise your hand.
I was going to just say that just to go back to the point that I suppose we learned a huge amount from our interaction with patients. And, you know, I think the three methods that we've seen from home, from Sarah, from ours, they're all coming to the same conclusion. Like, it's cooperation, because you can start with the clinical practice guideline, but it has to be the lived experience, what's happening on a day-to-day basis and what does the patient need. And really what we learned is that it really has to be a primary care level. And this came from a webinar that we had with GPs nationally, that GPs would say, well, how do I find out about fertility? I can't read 25 pages of a care guide of CPG. They want to know, what do I do for my patient in my practice? Because with COVID, in our practice, 97% of patients have been able to attend the highly specialized clinic. So it's the day-to-day experience. So you can do a patient narrative to say, well, the patient needs all the different pieces, and you can do a clinical guideline. You can start in whichever sequence you like, but they have to work together. And I also want to point out just one point that Sarah pointed, you don't always have a clinical practice guideline. So I'm working on the knowledge and training group in the ERNs. And as you know, there's only about 39 that have been endorsed by Orphanet in the ERNs, CPGs. So we have to move on. But I think that, you know, I want to make the point that it's both. It's the clinical practice guideline adapted to the patient needs, and the voice can come either for either how the sequence works depends on your local process. And I think they're all work, but it's just working together, and that's what our bottom line is, a cooperative model.
Super. Thanks, Eileen. I must say there was lots of positivity. I think the messages that, you know, when you engaging with your patient community in Ireland, and I think Holmes mentioned it as well as Sarah, the feedback from the patients for their care, there was commonality in the messages, and, you know, this coordination of care, and that resonated with a lot of people who were participating in today's webinar. So I think there was a question about resources, you know, that added need for coordination, how that could be supported locally and how things can be redesigned. Is that, have you got to that stage with the Irish pathways yet, Eileen, in terms of seeing how, you know, the additional services which are needed, or the enhanced aspect because of the rare needs?
So what Alana pointed out there is that there's an aspirational component to this. So we don't have the level of commissioning in Ireland for rare diseases as in the UK. And one reason is we've a population of 5 million, there's 60 million in the UK. But what this does bring to the table is, what does best practice look like? So, and looking at the European standards, looking at what, if there's a clinical practice guideline or there is a clinical decision tool, that our commissioners are not really what's the evidence? So they're overwhelmed with COVID and with bed crisis. They want to know what's best practice. And so we think developing a model with patients will lead to better commissioning because it's evidence-based. So, okay. And yes, and we don't have, obviously, for some of the pathways, I mean, there is one or two pathways in Ireland that are very well funded. And I won't mention the examples here, but then there's others that are starting off. But coming back to care coordination, ideally, you know, we heard this from European Patient Forum, every patient with a rare disease would need a coordination, but our feeling at the moment in the Salon to Care model with the model in Ireland is the GPs and the families need to be more empowered themselves, so that the families need to go to the GP and say, I need physio in the community, I need an eye exam, I'm due for this. And it does work for some conditions, and they can't, as I repeat it again, they can't read through 50 pages of a guideline. They have to know, how about the eyes? Where do I go? if it's sickle cell, you know, when do I need to transfuse? They need very, very easy messages for the 10-minute consultation with the GP, that the GP knows exactly where to go. And it isn't in Ireland at the moment, it isn't all going to hospitals. It's very much going to be in the community. That's the coordination. So I don't see how we're going to have funding for coordination in specialist care when the emphasis for us is more in the community. And I think patient feedback would be in the community is better placed for many of these conditions that are chronic and need multidisciplinary care.
But empowerment of patients and families to also navigate, I think, is also a very strong message. I'm going to just jump to Holmes, really. And there was a message from Dominique from Austria, and it's Austria, I think, it's quite a decentralized system like Germany. You know, how have you managed the pooling and centralization of on coordination in your federated country with a very decentralized competencies and fragmented healthcare? That was the question.
How did we manage that? I think it's so I think it's one factor is that we actually founded rare disease centers, which by well, in terms of their role and now and also in terms of how they are defined in the healthcare system, are the points where highly specialized services for rare disease center a patient can be provided. So it's per se a center, and I think this is one of the key things. And then I think I think we can harmonize across these rare disease centers because what we're talking about is a highly specialized service, and as of yet, and that's perhaps another factor, as of yet it's being implemented through a specific care contract. And perhaps I don't go too much into details. It's a care contract which needs to be concluded with each of the healthcare insurances separately. So it's not as easy as it sounds at the moment, but it's workable. And then I think the real centralization, and I think where we kind of change the system, is really the genomic sequencing. And there we have just 4 centers which provide the respective quality. And how we did that? So we did it by defining quality criteria for genome sequencing. And this quality definition was accepted by the healthcare insurances. And this quality definition actually is combines 2 things. One is the quality of the sequencing, and the other thing is the link to the respective clinical center. And by that, just a very few centers which can provide both are left over. And that's accepted.
Thanks, Holmes. Ines, you wanted to comment?
I want to follow up on this one. Really, thank you for your presentations because they're brilliant. Alana and Eileen were mentioning care pathways as a advocacy tool for business planning and service commissioning, etc. So, Holm, what was first? Did you define the undiagnosed care pathway and then you convinced kind of the health system, the health authorities to centralize services? Or what was first? The services were centralized and that was, clear, and then the care pathway came. Did you use the care pathway as an advocacy tool to get them to organize these services in a centralized manner? That's the question.
So the centralized service was already part of the care pathway. And that was because we defined the quality criteria with the care pathway. And by that, just a very few centers were able to actually meet those criteria.
We've got probably one chance for one more question, Ines. Is that okay?
Yeah, no, go ahead. And we can, one question for sure. Yeah.
So I think this is for Sarah. We had a question from Sandra about you are testing the interventions for 6 months. One of the common criticisms as to why some integrated care interventions don't show benefit is that the outcomes are assessed for a too short a period, not leaving enough room to capture the true impact. Is there a possibility to extend this intervention to monitor? What outcomes are you assessing for after 6 months?
Yes, what I think is that only the observation of the system without applying a specific organizational model compared with the applying a model with and without, only this comparison can add information on how a specific treatment can be done, how is cost effectiveness, since we are talking not only of organization and cost, but cost effectiveness. And it means outcome for the disease from the clinical point of view, satisfaction for patients, satisfaction for all the features involved in the pathway, the actors, not only patients, the physicians, the other features. So it is important, the specific question, for example, in the chat regarding infusion, drug infusion in day service, day hospital, or other kind of inpatient or outpatient clinic. It means that we have to observe, we have to demonstrate to the hospital manager and to the other stakeholders that organize a system in a better way means also acts on the costs. So I think that we have to demonstrate that, and only demonstrating we may improve. Otherwise, the example that we usually use answering to questions like this is that if we do not monitor the application of a patient care pathway of a specific clinical practice guidelines, is as thinking that we have a clinical practice guidelines and it's okay, it's the end. No, it is not the end, since we have to apply and we have to monitor how we are applying. Since I have to say, as doctors, that applying a clinical practice guidelines in a system not organized, it is impossible, since we have to consider many aspects, not only which kind of drug do you have to prescribe to a patient, but many other things, infusion therapy, how to organize many other activities. And if we do not monitor these activities, we have a clinical practice guidelines, we have a care pathways for a specific disease or group of disease, and we do not monitor and verify if we are applying, if we have results, we have nothing. So I think that only observing we can answer to this kind of questions, and what is we are trying to do applying this methodology, providing answers.
I mean, it's fantastic. You are doing KPIs and you are monitoring the implementation to, review and update. And I think it would be really interesting to get the results of your analysis. I think with a lot of the guidelines which have been developed so far, that step of implementation is still sort of needed. And I think that the development of your care pathways or your patient pathways and the work being done in Ireland and in Germany is a real way to implement what is those central guidelines. And I think that that's a great vehicle.
Exactly. It is exactly this. And we are very enthusiastic about that, since as a rare disease community, but as clinicians, doctors, patients, other stakeholders, actually, we are taking a look to the world of the health system, rare disease, and we are changing the world in this way. Otherwise, everything is stable, everything in the same way. We have to change. We have the duty as European Reference Network community to change, to create something innovative. It is a new decades, new years for this approach. So we are believers, and we share these thoughts together with Enrique Terol, that participated to the generation of this methodology. And he said in a meeting that we had in Brussels, specifically to talk about rare and path, okay, we are believers. but we have still to be believers. Otherwise, we are not a rare disease community.
I think it's impressive that you've got KPIs and your clinicians are collecting them. Incentivizing people to collect data is a tough call. There was a last comment in the chat about, critical to be able to access expertise cross-border, and I just wanted to underline, I think, Holmes' point about the essential role of the ERNs and the CPMS in that cross-border care, and I think that maybe is one of the key areas to focus on in future, to see how that can be meaningfully implemented to support cross-border accessing care, because I think that's missing at the moment. Ines?
Yes, we need to close I'm just answering to Russell.
I'll answer to Russell
on the chat. I need to close the webinar. Listen, there's one question I want to ask, and I'm sorry that I closed the webinar with a question, but I want to take advantage of having all of you here. Sarah was talking about a reference model that an ERN has developed. So Reconnect has developed something that they call a reference model, and they have piloted for system sclerosis. Alana and Eileen, this is a question for you, and also for Home. Imagine that you would have had such a reference model before you started your work on your care pathways at national level. Because right now, what Sarah and their team are doing is that this reference model, they have given it directly to healthcare providers to implement. And I'm just wondering this, in the middle, we have the health authorities, and you're doing unique. So there's these three levels: the ERN, the health authorities, and the HCPs. How do you see all these three things, or three levels, fitting together in this area of care pathways? What would you like the networks to do? Would you like to see more reference models, like the ones that developed by Reconnect? Would you like the ERNs to focus on clinical practice, on developing evidence? What is it that you need to have? Quickly, just 1 minute each of you.
What I want to answer is what we are doing. We have one direction, the European level. It is not good to say top and down. We have the centers within the European reference network, and we have tried to integrate in the local health system. Since, for example, we are a coordination team, we are European reference network, but we are a local level as well. So this is a direct contact, but we have all the needs, challenges, and all the best practice collected, implemented. We have to come back, and in this way, we have an intermediate position. So in Italy, we already talked together with some people from the Ministry of Health or other feature in order to say, okay, we are doing that. This is a long process, but this is the one way European reference network local level, then local level, national health, and then again come back, since it is good always to come back also to European reference network in order to improve. It is a circle. It is not a...
Aline?
Yeah, I know. I just want to say very quickly from the ERN Board of Member States, and this would resonate with Home, I think it's really, really important how we integrate the care pathway into ERNs, and that there would be support from the EC to local hospital managers of how to do this. And I think what Sarah is saying, it's not one size fits all, because, I mean, in Ireland, we certainly have to have the specialist expert services, but we just don't have the capacity to be, the same as, say, France, for example, at the hospitals. And so we have to have more help with the community. Even, the model can be shared across Europe, but that's going to be very different in every country. And back to ERN Path, I'm involved, for example, in the EBC, the Brain Council for PKU, and we have a care pathway, and they're looking at the care pathway probably with Sarah and Dr. Turchetti. But, we're coming to the same end point, but the practical logistical implementation of the guideline is the care pathway, which is based on local infrastructure. and it's launch of care for us in Ireland because of we don't have huge centres of expertise is the way. So I don't think one size fits all, but I think that the EC has to help with funding, with management, to help patients go through the care pathway to their local level, to the hospitals, to the CPMS, that they get the right answer and the right care at the right time. So that's what it's all about.
Thank you, Aline. Holm, do you want to add something?
Yeah, not much to add. I think the one bit I want to emphasize is that we really need the CPMS to be a structural, integrated part of the care pathways. I think this is one thing I would really like to emphasize from the ERN perspective.
Thanks. Alana?
Yes, very quickly. I think I agree that, you know, more access to network care that is achieved, that is really accessible, and also just our findings were really ERN endorsed clinical practice guidelines and clinical decision tools and resources to pull from, I think would be really helpful. So yeah.
Very good. So thank you all. Thank you, Matt, for being there and helping out with questions, and for being there in general. And take good care. I hope this was useful for everyone. We will upload the recording in our YouTube channel. Thank you for the participants also for being so switched on and for your questions. It's been great. And yeah, we'll continue the discussion at some other point. Ciao, everyone.
Thank you.
Thanks.
Thank you.
Bye.
Bye-bye.